made your life a whole lot easier because you anticipate that they are coming in with pain. And as you keep growing older, then things come in with things associated with pain come in, okay? Your back starts aching because you've been using it wrongly. The joints start aching because you've been using them badly. So chronic pain comes into the picture. So pain is generally associated with a loss of productivity because you cannot function well, okay? It is associated with disability, meaning that you are not able to do the things you would ideally accomplish. If your knees are paining, then you cannot go for a run. If your knees are paining, then you cannot walk for a very long time, okay? And then increased expenditure. You imagine that you've got to wake up and buy medication every single day, a Panadol here, diclofenac. And as time goes on, there are going to be more and more expensive medications that keep coming into the country that we've got to address. And unfortunately, either we don't know about it or we do not have the tools that would ideally enable us to address the issue of pain. So it is extremely, extremely poorly managed, and we shall be seeing that much later. This famous guy called Osler, William Osler, you might have heard of Osler's nodes somewhere in your training, said that in order to treat something, we must first learn to recognize it. And unless we actively go and seek out pain, people are not going to tell you much about it. Many times it is you are interested in the pulse, you are interested in the blood pressure, but you never actually get to ask your patient about the whole concept of pain and what exactly they are feeling at that point. Okay? So we all know this definition from the International Association for the Study of Pain, okay, that it is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Let's remember, and as we go along, we shall repeat again, that there is an emotional bit attached to pain. So the damage should not have occurred. When the child comes and they see you in your white coat, they're going to immediately think about you getting a needle, and they're already in pain. At that point, it is emotional, but it is one of the modifiers. And let's remember, people have actually stated this as the fifth vital sign. I repeat, it should be the fifth vital sign. Take your heart rate, take your respiratory rate, take your blood pressure, okay, your saturations, and remember the fifth vital sign, pain at that particular point, okay? So it is either acute or chronic, and there are some differences. So when it comes to acute pain, we can generally identify the cause. Most of the time, we are able to identify the cause. If you have a cut on you, we know the pain starts around the area of the cut. We don't expect it to be on the opposite limb that does not have the cut. Unlike chronic pain, for which many times we don't know the cause, or even if we've addressed the cause, it may just be persistent. So people are going to come to you and tell you, I have back pain. And you are going to take radiology images, or you are going to assess them, and you cannot be able to point out that this is the actual cause. There is no prolapsed disc, there is no nerve compression, but they will keep complaining about chronic pain, or they will say the back pain. The duration is short, it's well characterized. Yeah? Unlike chronic pain, which often persists after what you would ideally think is the ideal healing time, usually about 3 months. Someone who has had an injury should have healed. But this pain just remains there for forever and ever. We know there is a role for acute pain. Say if you put your hand over a flame and you started feeling pain, you will withdraw it, meaning that you are going to stop further damage in that case. There are individuals who are not able to perceive pain, so they are associated with actually injuring themselves over and over again because they've lost out on that physiological role for the acute pain. We've said chronic pain is usually coming in with old age, but we actually don't know what kind of role it is going to play at that particular point. And then when it comes to the treatment approach, we usually expect that with acute pain, once you treat the underlying cause, then with time or immediately, you are going to get rid of the pain. Chronic pain just seems to persist for forever and ever, and ultimately you end up just trying to get someone to function at that particular point of time. So reduce it to the point where they can actually function, but it will remain there in the background. So types of pain are quite many, okay? I've just listed a few here. Nociceptive pain, which is quite well localized. It has a definite duration, okay? And it stems or starts with the direct activation of the nociceptors by noxious stimuli. Neuropathic pain, usually now getting to the end of, it is associated with chronic pain, okay? So diseases or injuries to the peripheral or central nervous system, okay? So patients with diabetes are going to come and tell you, my foot is paining, okay? Because maybe the the blood supply to the nerve is affected. Right? Sometimes you have tumors infiltrating, or sometimes damage to the nerve with failure to heal very well. So things like phantom pain. Then types of neuropathic pain. Inflammatory pain due to tissue damage and then the resulting inflammation. So the mediators, like we shall see, are going to sensitize all these nociceptors all over the place. And then sometimes you have functional pain where people cannot process pain signals very well. So it's difficult to actually look at, it's difficult to treat them because they have some kind of chronic pain. So to just look at the physiology, I find this model quite interesting, and it is something that you actually look at when you are managing pain. And this is what we shall be using throughout. So if you look at this individual, okay, they are putting their foot next to a flame. And what you are going to have at that point is transduction, okay, which we are going to look at in detail. Then that signal is going to be transmitted, okay, along the nerve to the central nervous system, which carries it to the higher centers, the thalamus and then the cortex, okay. Along that, you are going to have modulation, both upwards and backwards. We are going to look at that. So a transducer is anything that moves one kind of energy, that converts one kind of energy into another. That is the definition of a transducer. So in this case, we are converting mechanical, thermal, chemical into an electrical energy. So we have these nociceptors, which are free nerve endings all over the body. And some of them are very specific to either mechanical or thermal or chemical stimuli. Some of them actually combine two, either thermal and chemical or mechanical and chemical. And then once they interface with these stimuli or these forms of energy, then they're going to convert them into an electrical signal. So nociceptors are at the end of either alpha delta or C fibers, which we are going to look at. Okay. So earlier on, I talked about the fact that some of our treatment modalities are associated with pain. And I'm going to initially concentrate on the surgery. Okay. So the kinds of operative surgeries that we tend to have in our hospital involve opening. Okay, so let's take a laparotomy where you're going to put your surgical blade onto the skin and you open. So you are going to have inflammation in that area because you are stimulating of the inflammation that goes to the surrounding area. What you are going to end up with is that those nociceptors in the surrounding area, because they have been exposed to these different kinds of inflammatory chemicals, they are going to be more susceptible to the signal transduction. What then happens is that whereas you have an incision, say over here, you're going to find a nociceptor over here that once you even just apply a bit of pressure to it, it is going to report pain. Okay, so it is going to transduce a signal that will be interpreted as a painful one. And that is one of the things that we term as hyperalgesia happening. Okay. So we've talked about we've talked about the alpha delta and the C fibers, which we are going to look at in detail. But there are also some other alpha betas that play a role, especially in chronic pain. But we are going to concentrate mainly on the alpha delta, okay, and the C nociceptors. So the alpha delta are myelinated. And if you remember from your physiology, they talked about saltatory conduction. So they are quite fast because the signal is jumping from one node of Ranvier to another, sometimes actually skipping about 2 or 3 of them. So they are pretty fast. And they tend to transmit what will be described as burning, stabbing, pricking, or aching pain. It's extremely well localized. Okay, and we have 2 types, but they are going to conduct at different speeds. On the other side, C nociceptors are unmyelinated. They are pretty slow. Okay, and this is pain that comes in much later, and it's going to be described as throbbing or dull aching pain. So for any of you who's had any kind of injury, maybe a prick, what you are going to first feel initially is going to be the pricking or stabbing pain. And then a few minutes later, that's when the throbbing comes into the picture. So what has actually happened to you is that the A delta have been able to transmit, and then the slow fibers are coming in much later. So from the nociceptor at the periphery, this signal is going to go to the dorsal horn. Okay, that's where the second order neurons synapse with the first order neurons, and it is then going to be transmitted upwards via the spinothalamic tract, and then you have a role for the other spinal-reticular tracts that bring out down. You have a role for the spinal-reticular and the spinomesencephalic tracts. At this point, what you could have initially is, depending on what kind of signal you have, sometimes you are going to have what is called the spinal reflex, okay? That the signal comes, and then something that is going to stop further injury is going to happen, okay? That is, all that gets resolved around there. So you have your first order neuron bringing, but then an immediate signal is sent back to prevent further injury before we even get that transmission of that signal to, let's always remember what is going to happen at that point. So along the points of, along those synapses that we just looked at over there and over there, okay, what happens is pain modulation. So pain modulation is I'll start with the fact that the degree of tissue injury is not always proportional to the pain that is experienced, either for an individual or even a group. And the factors that come into play here are what we term pain modulation. That sometimes you have the damping down of a signal or upregulating it. So the things that upregulate are the extrainhibitory factors. So when the signal comes and those substances are released in the synaptic cleft over there, then you are going to have an upregulation of the signal. So meaning that the second order neuron is going to fire much more, or you are going to have many more neurons that are then going to be able to fire off. That is causing excitement. So someone will perceive more pain compared to what the degree of injury has caused. Then you also have the inhibitory factors, okay? So things like the endorphins, which we call the naturally occurring opioids. Those ones are going to damp. They are going to reduce on how much firing happens in the second order neuron, okay? So meaning that ultimately you are going to reduce on how much is transmitted up to the brain. So that is pain modulation. And this is an area of study that is of interest to many, because this helps us to actually manage the pain appropriately. So if we can be able to get drugs that are going to act in those areas, then we are going to be able to manage pain much better, both chronic and acute. Then the perception is going to happen at the level of the cortex. The signal is transmitted through and gets there, and then you're going to have what is termed, or someone is going to interpret whatever they are feeding, and is also going to be able to quantify it for you. And there are going to be there are factors that actually influence what is happening. Gender of the patient, okay? We actually tend to think that women feel pain much more. It's just that probably they are more likely to complain about it. Because for the hospitals that, if you keep looking at the hospitals, or if you keep doing your rounds, you're going to find that men are going to be complaining much more about the pain. And well, we once had a visitor here who went to maternity ward and declared that all African women are made of metal, because she could not imagine all the women who are pushing without any kind of analgesia. Gender of the patient assessing, of the physician assessing the patient, is also going to influence. Someone is likely to complain about their pain when they are talking to a female doctor compared to a male doctor, because they expect a degree of care. The child will declare that I have pain because they are talking to someone who they could picture as their mother. So it's not likely that they will confess to the male doctor about their pain. Then number of physicians present at an assessment. I usually would like to, I usually help people perceive this in terms of those major rounds that are conducted on the wards. So you imagine that you came in with, or you imagine the patient who has a fracture on that ward, and there is this major ward round that has 20 fourth years who have come to study about the fracture. Then they come, they look, they talk, speak their English. Someone is fired questions, they cannot even say anything. And after about 30 minutes, people walk away. Someone is going to look at the number of white coats around them to actually reflect the degree of seriousness of their condition, which makes them perceive greater pain in the process. Okay. Then time of day, people tend to feel more pain towards the evenings. What is the physiological response? Okay. Pain should not be naturally occurring. So they are going, once people are perceiving pain and experiencing pain, there are a number of changes that happen within the body, and we are going to look at them in detail, okay? But I would like you to concentrate and look at the fact that there is a sympathetic activation, and we use this to view that when we are, as one of the measures when you have a patient under general anesthesia, that when the patient is under, they cannot communicate to you. One of the key things you're going to look at is the effect of the sympathetic activation. If you've not given an analgesic, what's going to happen is that once the incision happens, you then see issues with cardiovascular stimulation. The blood pressure goes up, the pulse goes up through the roof. Okay, that is sympathetic. Much slower that will manifest is going to be the pituitary adrenal axis activation. But we are going to look at that in detail over here. This is usually a busy slide, but I took plenty of time to pick that from this particular paper. If you look in the corner there, you're going to see a paper. Sorry. There is a paper there, okay, that is worth looking at. Let me just try to look at a few of the things that could happen. So let's look at someone who is having a laparotomy, and we are going to cause tissue injury as a result of our abdominal wall incision, okay? So if we've not managed that pain very well, we are going to have a sympathetic axis activation. And one of the key things that are going to happen is tachycardia and hypertension. So in order for the patient to actually maintain that heart rate at that level, it is going to affect in one way or the other. If you remember from your physiology, the heart gets blood supply during diastole, and systole has a fixed phase of time. So every time you have an increase in the heart rate, what you are cutting back is diastolic time. And this is one of the key things that you are going to end up with a reduced time for the supply. This is how we end up with very, very fancy DVTs, and ultimately we get patients dying. We take plenty of time to look at the behavioral and physiological sequence of what we are doing to the patients. We are going to see that there is a very big role for pain management in the outcomes of our patients. We've got to manage our pain, the patient's pain appropriately if we are going to have the good results of our surgery. Moderate to severe or to extreme pain. 75%. So that is 7 to 8 of every 10 patients that you are operating on are saying, I have moderate to extreme pain. I would wish for you to think about how bad the problem is in our setting, where we do not even ask about pain. So, untreated postoperative pain can progress to chronic pain. And we've seen that with productivity, you're going to have a degree of disability. Some of you know your grandparents who are always complaining about Oruchindo, okay? That scar that is always paining, and then they cannot be able to function. There's going to be impaired rehabilitation. So there are surgeries that require, say, physiotherapy immediately after, say, knee replacement, some chest physiotherapy for someone who's had a thoracic incision. So if someone is in pain, they are definitely not going to be able to function or to participate in their rehabilitation, which delays their recovery. And in that case, what you are going to have is someone with increased hospital length of stay, which has financial implications. Okay. Any extra day that someone spends in hospital, even in MRRH, has financial implications because they will need to eat while they are there. The attendant will need to eat. Okay. They are losing out on money they would be making at home, even if they are supposed to be digging. So all those are cost implications. And before you know, this has transferred down to the children and so on and so on. So someone once talked about the fact that a patient needs close to about $150. There was actually a study that was done on surgical ward. The healthcare service seems to be free, but they actually need about 300 to 500,000 shillings in order to have a surgical process done. So we said that pain should be termed or is termed the fifth vital sign. We need to know how much it hurts. Why? Because if we do not know, then we cannot intervene. If we cannot quantify it, we shall not know whether there's been any difference in any of our interventions, or how much or the magnitude of that difference when we give an intervention in the process. So we need to know how terrible the pain is. And what is the gold standard? Without reproducible biological precise diagnostic tests that measure pain, the self-report remains the gold standard. The patient tells us, and we need to believe them. I repeat, only the patient can tell you the degree of pain which they are experiencing. Because we said the degree of injury is not commensurate with the experience of pain. So we can only take the patient by their word, okay? So don't walk to the patient because another one had the same procedure and they're not in pain. And this patient is telling you, I'm in extreme pain. To put a vertical line along this line where they think their pain is, okay? So let's say they're going to put that over there. So what you are going to do next is come and measure to that point. And let's say it is 70 millimeters. Okay, so that is your report, that it is 70%. Okay, so it is a 100 millimeter line, and you measure from one side to wherever the patient puts a mark. So the idea is that when you give an intervention, then you will bring it back, and the patient is going to say, put it their mark over there. And then you know that your intervention actually probably worsened things. If they put it there, then you know you are doing the right thing in the process. The next one is the numeric rating scale. And you are going to tell the patient that you have an 11-point scale from 0 to 10. And they are going to give you a figure that correlates with their pain. So they are going to tell you, I have a score of 8 out of 10. Sometimes you go to someone, like I had over the weekend, and they're going to tell you it is 15 out of 10. Then you know that that is extreme pain, or they are malingering in the process. So that most common is the numeric rating scale. And this is something that you need to be using on your ward rounds every single day. Fifth vital, where is your pain? The verbal scale just makes you think of how to choose a word. And in this case, what we are doing is we are transferring, we can be able to convert that into the verbal. So that is none, that is mild, that's moderate, and that is severe, okay? Then the Wong-Becker-Fessel scale is used in children who you observe, okay? Or they can actually tell you a few things, okay? Like hurts even more or hurts a whole lot. Now, we need to be thinking about the universal pain assessment tool. Many times you're going to find a patient who has modified their behavior to try and minimize pain. You're going to ask them, how bad is the pain? And they're going to tell you, oh, on the scale, it is at 3. But that is because they have not moved at all. We need to be able to quantify pain in different ways, okay? So someone had their laparotomy, they are walking around, and they tell you, oh, the score is 3. That is going to be believable. But if someone is scoring their pain at 3 while they have not moved out of bed, you need to ask them, what happens when you cough? What happens when you sit up? What happens? How bad is the pain when you walk around? And then you are going to get a true picture, because you need this patient to be mobile to try and prevent complications in the process. So this is just showing you that on, say, day 1 over there, okay? Someone has a visual analog score, which would fit them into probably that is mild pain while they are resting. But the moment they cough, they are already into severe pain. If you do not do anything about this problem, you are going to have a patient who keeps shallow breathing. They are going to get atelectasis. This is a patient who is not going to get out of bed. There is a flux scale that we use for infants mainly. And you can see it is sort of modeled on what would be termed, on what is similar to either the APGAR score or mainly the APGAR score. Okay, so you have to look at their face, okay, and you score them. Okay, so the lowest score is going to be a 5 out of 10. That tells you that the child has no pain at all. If they are scoring 15, okay. So if you remember what child who had an intussusception reduced through an abdominal incision, then the flux scale is what is going to make sense in that child, other than the grandmother. So you are looking at the face, the legs activity, their cry, and degree of consolability. How do we manage pain? We have to go back to the model: transduction, transmission, modulation, and perception. And at all those different levels, there is something you can do. If you combine the modes, what you're going to end up having is better pain management, and that's what is termed multimodal analgesia. So at the point of transduction, we have a role for local anesthetics. We also have a role for anti-inflammatory drugs, because they are going to reduce on the degree of inflammation, meaning that there will be less sensitization of the nociceptors. At the point of transmission, we still have local anesthetics playing a role. We still have, now we get opioids at the point of modulation, okay, and alpha agonists, alpha 2 agonists. And then in perception, we have opioids again, but we also bring in anxiolytics, patient education, and antidepressants. NMDA antagonists and calcium channel blockers are also playing a big role in that. So this picture is to basically show you where all the molecules that should be targeting and where they're targeting. Okay, so if you look over there, you're going to see that you have your sodium channel that is being blocked with the local anesthetics. We have alpha 2 receptors. We have NMDA receptors. Okay, so this is to just take you back to your pharmacology and remember how it comes to apply in the process. This slide is also, but also to remember the different classes and their potential relevant side effects. I'm going to pay more attention to this. So one of the most commonly prescribed analgesics happens to be the NSAID class. We keep throwing diclofenac, ibuprofen, ketoprofen. They are managing pain. There are certain things that we've got to be very, very mindful about. We've seen patients who've come in and they are not good candidates for NSAIDs. I repeat, there are patients who have come in and they are not good candidates for NSAIDs because they already have predisposing factors to acute renal injury. If you then give them an NSAID, what's going to happen is that you are going to tip them over. And what is going to happen next? Patient will need dialysis for the rest of their lives. So every time you are going to give a patient a drug, ask yourself, is it the right drug I'm going to give? If I'm giving them an NSAID, are they already predisposed to renal failure? Or am I the one going to tip them over? You may not know it during your time, but you might have done a whole lot more harm to the patient down the line. Paracetamol, very, very good drug. The beautiful thing right now is that we even have it in IV formulation. But we've got to be mindful of the hepatic toxicity. It's a very, very big issue, especially, again, you've got to ask yourself, what am I doing to the patient? Am I doing them more harm or not? We also have to talk about the route of administration. So many times the patient comes and we are going to, they're hypotensive and we end up giving the drug intramuscularly. And we forget what is going to happen to this patient down the line. First of all, you've given the drug intramuscularly, but there is little to no blood supply into that compartment at that point. So if you remember your compartment model for when you are talking about pharmacokinetics and dynamics. So that drug is going to remain there, not being used. Why? Because we learned that all the practice has been pethidine is given IM, and you've not seen anyone who's been practicing giving IV pethidine. So you give the whatever IM, and you think you've treated the patient's pain, but because you did not follow up, your patient is still complaining of a lot of pain. What happens down the line is your patient may go to the ward, someone makes gets the drug that has been prescribed at that point, or the IV fluids, and that raises the blood pressure. And then this drug now gets washed into the system. And you are not there at that point to actually see the impact of your medication. So let's be mindful of the route of administration of these drugs. Okay. So NSAID, pyretic, and analgesic. Go back to your pharmacy case. No, that happens. Okay. So, and under that, we have spinal epidural analgesia. They are not the same, but we do them. Okay. Regional nerve blocks. Some of you might have been lucky during your rotation, or you will be lucky during your rotations, where you'll be able to see some nerve blocks being done. Sometimes you have wound infiltration. So where you do not have the facilities to not fight with the anesthesia provider when they ask you to infiltrate the wound with local anesthetic, a long-acting one like bupivacaine. If the patient is up, because some of these blocks are done either blind or use a nerve stimulator or use ultrasound, but the risk for nerve injury increases as you head towards the blind. Previously, we were very, very excited about this drug. It's called Exparel, or liposomal bupivacaine. So if you look at that, what they did was package bupivacaine into liposomes, and this is what you infiltrated into the wound, with a very, very big promise that if you infiltrated today, this thing would last for about 3 days. Unfortunately, subsequent studies never got to prove that, because they showed it wasn't any superior to the usual bupivacaine that we have. Yet it was about 200 times the cost of this. Okay, so hopefully in the future we shall get a better formulation that can promise someone analgesia for. So this is an example of the regional block, and would you? Okay, so an humerus. Okay, so some of you may have seen someone with a fractured humerus, especially, around there. Just an interscalene block can provide either sufficient analgesia or anesthesia to enable the patient to be pain-free for up to 24 hours. So let's look at what it would look like on the ultrasound. Okay, so what you have over there, so this is the same image. But here it's just to explain that that is muscle, and over there you have C5, C6, and C7 nerve roots. So what happens that you bring in your spinal needle, post local will be able to. So what you are going to see, this requires you to have a little bit of faith, but this is say a picture that you would be able to see on the ultrasound. And what you have over there is C5, C6, C7. Okay, and what you are going to see is the needle coming in from that direction, heading there to infiltrate the. So you have a needle over there, and he heads into the interscalene groove. Okay, and what you have next is local anesthetic that is coming in, and you can see it is pushing the nerve roots away. Okay, so this is why we keep playing around with ultrasound in theater. Okay, so that you can be able to block off that. You probably just play that again. Okay, C5, C6, C7. Okay, it's also termed the traffic light sign. Okay, anterior, this is anterior scalene, that's middle scalene, and nerve block needle coming in and getting into the is over nerve root injury. So that's the beauty. As you can see, the local keeps spreading, heading even to that root. Okay, and even this side downwards. You give it about 15, 20 minutes, and you'll have someone whose shoulder is properly blocked, and you will be pain-free in the process. Over here is a picture of what we call. So if you remember the muscles of the anterior abdominal wall, you have the external oblique. Okay, so on top, just under the skin and subcutaneous oblique, I'm going to leave out the rectus. There are some blocks that happen with the rectus shape. You have the internal oblique muscle and the transversus abdominis muscle. And then just below that is the peritoneum and then the peritoneal cavity. So if you remember from your anatomy, the nerves come from that side in the plane that has between the internal oblique and transversus abdominis muscle. So till then perforate the skin. So if we go into what is termed the triangle and the mid-clavicular line, nerves, that plane, abdominis plane muscle, then you'll have blocked plenty of the supply that goes to the analgesia manage to actually fit into that plane. And therefore, when the patient is on the ward, what they keep doing is keep pushing in local anesthetic to block. The beauty about this is that it blocks anything that is below the umbilicus quite well. Unfortunately, it will not address the visceral pain in the process. So that is something that you should be mindful about. The little thing I will talk about epidural analgesia is that you can do it almost at any level that you want. We are putting local anesthetic of varying concentration into the epidural space. There are techniques of how to achieve that. Some of you might have noted those during your rotation. I think the first group might have seen one. And this really is a gold standard for labor pain or labor analgesia. So ladies who are on the call, please make sure that you save enough money or you get enough money from that gentleman so that you actually do get a labor analgesic. It is not fashionable at all to experience pain while you are in labor, okay? You are not pleasing anyone in the process. Least and most of all yourself at that point. So I've already hinted that every time you come up with an analgesic plan, consider the site of action, side effects of the drugs used, what are the drug interactions, okay? And then the route and method of administration and patients' comorbidities, because they play a very big role as you choose the drugs. Preemptive analgesia means that we're administering analgesics prior to the onset of noxious stimuli. Example is when we are in the operating room, we know someone is going to make an incision, it's going to be painful. So before the insult happens, so a lot of the side effects that would end up having in the process. And it's always superior when you use multiple pharmacological agents. I would like to use this picture that I picked from a colleague, okay, to just show you the importance of giving the right medicine at the right time so that the patient does not feel pain, okay? And what impressed me most is that this happens to be oromorphine, for those of you who may not know. Jonathan, then Mujuni. Please go ahead with the question.
Yes, thank you so much, Dr. Kiwanuka. My question is, in relation to if someone has had a traumatic accident and probably has a fracture of the femur, is bleeding, and someone is literally in severe pain, you go straight to probably pethidine, a stronger opioid, and then going to diclofenac earlier, or most times we should first go through the pain ladder slowly but surely.
Okay. Thanks very much.
Thank you,
for that.
Doctor. My question is about that pain in the evening thing. I have a relative who asked me that question and I had no answer. So I would like you to elaborate on that. Why is pain more in the evening?
So they had noticed. Okay, thanks very much. Walter.
Thank you so much, Doctor. My question is about the alpha-2 agonists in pain management. When would you want to consider?
Okay, thanks. Any other question? Okay, I'll start with the first one. Someone has, you may have noticed that I did not talk about the pain ladder because in our kind of practice, that doesn't make much sense. What we try to do is either use lower doses or higher doses. We could use pethidine across all that spectrum, but there are also effects that come with that much later. So when someone has a fracture femur, one of the key things you're going to know, or one of the very, very obvious things, is that they are going to have severe pain. Fractures associated with severe pain, okay? Until they are they've been modified with it. There is an alternative, which would be to actually do for them a femoral nerve block. The femoral nerve block is going to reduce their pain much, much easier, and you may be able to avoid quite a lot of the complications of that are associated with the opioids. But please, you go ahead with the pethidine as long as they're a good candidate. If you are to go for diclofenac, it's good for bone pain. Just remember what's the side effect profile for that. Okay. The next one has to do with the next question was pain in the evening. That has to do with the hormonal balance across the day, especially your, if you remember from the slide that had the adrenal, pituitary adrenal axis, that is the physiology behind it. And there's going to be the role that those hormones play in the perception of pain. That is why we end up, I don't have the time to go into the details at that point or at this point in time. But when you come for MMed, we shall talk about that in detail. The last question at this point was about the alpha-2 agonists. So clonidine, dexmedetomidine, clonidine, this is usually a common thing, and someone was talking about it before, and it was questioned about the hypotension that would result. So usually when we are looking at clonidine for its analgesic effect, what we'd want to be doing is giving it quite close to where the receptors are, the receptors of our interest in that, which would be in the spinal cord and the brain. So Usually you'll see, you may find some people who practice by giving clonidine as part of their spinal, okay? Or their caudal block. That would be where the role comes in. We are not here to discuss things regarding drug doses. They are always written somewhere. Or when you come for MMed, then we shall practice. Dexmedetomidine is a wonderful drug, and the beautiful thing is that it's now available in Uganda. Probably not. Okay. And it is wonderful because it provides you the sedation, provides you the analgesia, and actually maintains your respiratory system. So a very good drug when you're dealing with especially very frail patients. So hopefully you'll practice with it as time comes along, okay? Any other issues? Any other questions?
Yes, sir. Sorry, Doctor, just one.
Yes.
One more
Yes,
question.
Jonathan.
Quite often I've had clinician cause we see especially depression when morphine is used, let's say, in management of severe pain or any of the opioids. How often do we see a side effect?
Could you just repeat the question?
I've had quite often that even in pharmacology, that respiratory depression can happen with opioid use. So, and my question is, how often do we see respiratory depression coming in opioid usage, or it's not as common as a side effect of opioid usage for management of pain? That's on ward.
Okay. I can't give you the figures from Mbarara, okay? Yes. But when it is always going to depend upon your practice. Okay. There is a paper, it's quite an old paper, but those of you who have seen the Macintosh blade, the guy who wrote that paper, it's called Macintosh. And he made the statement that he had seen a lot of standard doses of morphine being given to substandard patients. He meant that, you know, when we come to anesthesia, it's not a one size fits all. When we come and look and say the dose of morphine is 0.1 milligrams per kilogram, it does not mean that when you come in and you are 300 kilograms, then we are going to give you 30 milligrams. Your other comorbidities are going to play a role. Because if you have COPD and I give you, or if you have obstructive sleep apnea and I give you the so-called standard dose of morphine of 0.1, you are definitely going to have the complications, okay? So we always tailor the dose of the drug to that particular patient. And in that way, you actually end up reducing on the degree of or the amount of side effects. And the other thing is that when we combine different levels, so transduction, we give a block, we give a bit of paracetamol, and then we give morphine, you're going to find that you are going to end up needing less morphine in the process. So as we deal with any of those patients, please avoid going for what is termed the so-called standard, that every patient gets 100 milligrams of pethidine. Then you are going to have the side effects. Look at the patient, understand their physiology and the pathology behind it, and then you're going to be able to administer the right drug in the right quantities. Okay? Thank you. Unless I have any other concern. Any other issue? Yes, John.
Yes, Doctor. Thank you for the. My question is, I wanted you to get guidance from you how we would manage patients with the head injuries in emergency room who are scheduled for bar hole emergency surgery. How do we manage that pain?
Does the patient have comorbidities?
No, maybe just another TA case. Well, just coming into emergency room and then
Yes.
you are seen that we have a head injury. We're expected to be have
What is the GCS that the patient has? You are breaking. Hello. Okay. Well, John is breaking up, but let me try and address this issue. So someone is coming in for bar holes. Most likely they've been having, so they've had a chronic subdural or epidural. That's why they require bar holes at that point. So yes, it's true they're going to have a headache in that in that instance. Again, consider the kind of patient you have and then think about the pharmacology. In this case, one of the key things we don't want is anything that is likely to increase the likelihood of the patient convulsing. That's why we keep avoiding pethidine, because one of the metabolites of pethidine is called norpethidine, actually is associated with an increase in convulsions. Okay, so pethidine, head injury, no. So what then do we have in the process? So think about paracetamol, okay, as the start point process. Try to avoid NSAIDs. Why? Because this patient is going in for injury. And remember the fact that NSAIDs actually impact on platelet aggregation. Okay, so they have an antiplatelet effect. So you may go in, if you give your diclofenac at that point, you may end up having more trouble with the bleeding intra-op. But on top of that, if the platelets are not aggregating very well, then you're still going to have, you may end up accumulating a hematoma again later on. Then what are you left with is to come in with things like with the opioids. And in this case, you're either going to be thinking about fentanyl or morphine. And one of the key things is to think about, it's about titrating to effect. So if the patient has not yet gone in for surgery, but you're anticipating to go, you don't want to give a very big dose that is then going to knock out the patient, and then they get secondary head injury because they are hyperventilating. What you need to be thinking about is giving smaller doses and seeing the impact. So if I gave fentanyl at that point, I'm going to be assessing every 3 to 5 minutes, because that's when I expect its peak effect. If I give morphine, then I'm going to be waiting longer, maybe 20, up to about 20 minutes to achieve its maximal effect. If I gave morphine at point A and I just assess after 5 minutes and the patient is still complaining of a lot of pain, and I give more morphine, what's going to happen is that I'm going to keep accumulating before I achieve or before I get to know what the maximum effect is. So hence me talking about the fact that you need to know your pharmacology. Time to maximum effect plays a very, very crucial role in your choice of analgesia. I hope I've answered your question.
No. Thank you, Doctor. Issues? No, Doctor.
Okay, so if there are no other questions, thank you very much for indulging me, and have a good evening.